It starts.
Hello.
Hello.
Are you checking in for the Partners of World Health?
Hi.
Oh, there we
Yes, I
go.
am.
Okay. I'm trying to get it said it's going to begin shortly, I guess.
I can't hear Elizabeth.
I can't either.
Elizabeth, we can't hear you.
Good evening, everyone. Okay, Ron, I'm so glad. Okay, Arul, super. Thank you, Dr. Hull. Good evening again. My name is Elizabeth McClellan, and I'm the founder and president of Partners for World Health. And we want to welcome you all here this evening to our Global Health Education Series. And before we get started, just a few announcements, and also to let some of our people know a little bit more about us, because there are many new names, many new people that have joined us this evening. Partners for World Health is the only organization here in New England that collects medical consumables and equipment, and we collect them from all hospitals here in New England. Our base is in Portland, and we ship 2 containers a month out of our shipping center here in Portland, Maine, to different places in Africa, Asia, and the Middle East. This month, we just sent a container yesterday to Syria and another one to Mongolia. And last month we had Jamaica and Honduras, and then we're working on 2 more for March. So we're pretty excited about the work that we do. In addition, we run medical mission, a big medical mission program that will start up again in the summer. this year. And we've been, our medical mission program came to a screeching halt last January when the pandemic started. So to give you a few more insights, we are having several events in March. And on March 8th, Partners for World Health will be celebrating International Women's Day through a panel discussion. I'll be the moderator, and we have three women that are empowered women that are helping to empower other women in our world. These individuals are running international NGOs, and we're really excited to have them on board. You can find out more about it on Facebook and our Facebook page, and you can click on the link and you will be able to register. In addition, on March 9th, we have a evening event about our medical mission program. It's more of an orientation about the programs that we will offer this year, the balance of the year, and also the logistics behind our operation on a medical mission and the application process. So that's open to anyone who'd be interested in joining us, the March 9th. In addition, on March 25th, we have another event that Dr. Mahadevan from Fort Douglas and Dr. Ravi from India, Sinclair, India, will be speaking on oncology in India and on the surgical oncology services provided in the hospital started by Dr. Ravi in India, who's also a colleague of Dr. Mahadevan. So we want to welcome all of you here. If you stay to the end, we have several door prizes this evening, a variety of different things, and other little things that were actually made. This is pottery actually made by one of our volunteers. So we have 4 door prizes, and if you're here, your name is drawn out of the basket, we will be providing those to you and sending them to you if you're from far away. So don't worry, we're pretty good at packing things up around here. So I'd like to introduce to you our speakers this evening. Dr. Michael Curci, who many of you know, is a retired pediatric surgeon and did a general surgical program as the director at Maine Medical Center for many years here in Portland. And he's been involved with global medicine way back when he did an elective rotation in Liberia from years ago. So he's also spent many times in Haiti, at the Albert Schweitzer Hospital. And since he retired in 2008, he has continued his work in Tanzania, in Malawi, and Rwanda, focusing on pediatric surgery. And he's joined here this evening with Dr. Pandya, who is also a practicing pediatric surgeon at Maine Medical Center, who has had a very strong interest in global health and education and surgical outcomes. And together they have participated in pediatric surgery in Rwanda, and he's also had other trips in Tanzania and Kenya. So we want to welcome both of them here this evening to talk about their practice and pediatric surgery in a low-income countries. And I'd like to welcome both of you.
Okay.
Hey,
I see that Marie, somebody's speaking, I can't hear.
Okay, hello, good evening. So I'm Kartik Pandya. I hope you can see the slides okay. I'm really delighted that to join you tonight and for the opportunity that Partners in World Health has given us, and to spend some time with my longtime mentor and colleague, Michael Curci. Tonight, we'll talk about our experiences with what we think is a current state of the challenges and opportunities in low and middle income countries from really an important part of healthcare, which is the care of children with surgical diseases. We have no disclosures. The objectives really are to talk about healthcare delivery in two low and middle income countries, Tanzania and Rwanda, and the training models that the countries incorporate, and also our personal experiences with these different training models, and what we think and what the literature and people that think about global health work say would be really the best practices for medical missions and engagement over short and long-term medical missions. And then we'll have time for questions at the end. Just a little brief summary on the healthcare delivery in Tanzania. This is very similar to many developing countries and actually many countries that are not based on the strict Western model that we see in the United States. There's a broad base that is served by dispensaries and health centers, which can do dispensation of drugs and also take care of minor problems for the population. And then the next step in the referral goes up to the district and then to the regional and then to the referral hospitals. And the numbers of these are fewer and fewer as you go up. So dispensaries typically will serve populations of about 10 to 50,000 people. District hospitals will serve about 250,000 people. And in some provinces or states or territories where there isn't a clear district hospital that can fulfill these missions, the government will collaborate with a non-governmental organization, sometimes private organizations, to fulfill that need. Tanzania is different than Rwanda in that a lot of the healthcare training in Rwanda is based on the Western model. In Tanzania, they have a strong emphasis on using assistant medical officers, which are medical providers that have a baseline of medical knowledge and then can specialize into pediatrics, internal medicine, OBGYN, general surgery. But on any given day, they may be asked to perform duties that include obstetrics. If you're on call, then a mother that comes in, precipitous labor is not an uncommon problem. And despite you predominantly focusing on pediatrics, you may be asked to manage a mother in crisis, or a patient that comes in with peritonitis, and you may be internal medicine focused, but you'll have to take care of that patient. So that model has a shorter matriculation of having people starting from secondary school and going into medicine, but is limited by the specialization that can be provided in that way. There are medical doctors in Tanzania, but very few, and often will be centered in the urban areas. And so you may be in a district hospital that's essentially staffed by assistant medical officers with a few or maybe one medical doctor that serves as the medical director of that hospital, but doesn't provide the great burden of care that's needed. Other factors in the delivery of healthcare. So the healthcare spending in Tanzania is flat. It's about 7% of gross domestic product. And despite the costs going up, there's majority of that gap is funded by non-governmental organizations. So the actual spending has doubled over the last 10 years, but the amount that the government contributes is about the same. And about a quarter of the healthcare expenditures are out-of-pocket costs for the patients. And although the absolute amounts are small in many cases, they can be a great barrier, almost in the most cruel way you can imagine, in that if you have been able to secure the funds for a arduous journey to a hospital, that may take you much longer than should be for the small amount of traveling that you may have to do. And you have then arrived at the hospital, the actual money required to get therapy may be prohibitive, and you may have to rely on donations or funds gathered by your family or your village in order to pay for expenses that would seem trivial to many people in the Western world. I apologize for this slide. It's a little bit busy, but it also shows how the healthcare delivery in Rwanda is similar to Tanzania, but also is a little bit different in that in addition to the district hospitals, they'll have tertiary teaching hospitals where predominant training of the residents occur. And this model is similar to the way that the medical training in the US and the Western world is, that after college and after going into medical school, you then will go into a residency. The residency length varies based on what type of residency you enter into. In combination with the residency, there's also a service obligation, as these are government funded spots, and so you owe the government a certain amount of time at the between your portions of your residency, but then also at the end of your residency, at the end of your completion of your training. And that could include subspecialization training that you do at the expense of the government. I'm going to turn over the next portion to my colleague, Dr. Curci.
Welcome, and I'm glad you can all be here. What we want to emphasize is that there are several models for providing healthcare in developing countries, none of which is better than others, but they have a place given their infrastructure, their culture, their monetary expenditure. And you may find one model as time goes on progresses to another model. So this is a program in progress. You need to evaluate the needs of a specific population to decide which type of training model or healthcare model is best. This slide just shows the inequity of care throughout the globe, where our hemisphere has only 14% of the population, but accounts for almost 50% of healthcare workers and global expenditure. So there's a major disparity, and the question is, how can we correct this over time? My talk is really a personal travelogue since I've been involved with global health over a period of more than 50 years. And I've been involved with each of the dominant healthcare models. Besides going to Liberia as a medical student, my first extended experience was in Haiti at the Albert Schweitzer Hospital, which is a facility in the Artibonite Valley established by the Mellon family, the banker family from Pittsburgh, in which they created a medical facility 90 miles from Port-au-Prince, where the major population density agriculturally was situated. What is very impressive is, or not impressive, but sad to say, Haiti is the poorest country in the Western Hemisphere, yet is only within a little over an hour's trip by plane from Miami. This slide emphasizes that this is a service-oriented mission facility. It has a long-term commitment, but is dominated by expatriates. Service is their major interest, where education, passing on their knowledge to their local community was not very well established. In fairness, this is one model that has gone from mission to more locally serviced by the Haitian population. It now has both clinical doctors and administrative people running the hospital. So this is a transition from mission to more locally controlled care. There's a few slides here which demonstrate what the primary mission was at that time. Infectious and communicable diseases were the dominant interest, and which could be managed and got most of the publicity because it was easily demonstrated in terms of its benefits. This is an infection of a leg bone, the femur, and you can see the destruction in an infection that was delayed and in terms of its management. Neonatal tetanus we don't see anymore because you can immunize it, but this was very prevalent because the families would deliver out in the village, cut the placenta with instruments, the machete used out in the field, and tetanus became very prevalent. Before immunizations were available, or at the time they were, the families were instructed to bring the baby in with the placenta, let that be divided in the hospital and immunized. This is delayed tuberculosis. This is Pott's disease with a deformity of the spine, which can go on to neurological deficit untreated. The other disease which is prevalent throughout the developing world was malnutrition. This is kwashiorkor. The children are quite edematous, but as they lose their swelling with a better diet, you can see the wasted extremities in the child in the front. Now the World Health Organizations and other facilities can provide very simple supplemental diets to avoid this. So as a resident in training, I spent on 2 occasions 5 months out of my 5 years in training at the hospital, which is unusual, which wouldn't be allowed today under training requirements. When I started in practice in the Maine Medical Center in 1976, I continued to visit Haiti on an annual 2-week basis, initially with my family, but subsequently with the residents, nurses, and faculty from the Maine Medical Center. In addition to being involved with these patients who were very grateful, culturally, it was important for me and for my family to understand these major disparities and see the difference between what we had in our Western medicine and what was absent in the majority of countries. One of my daughters I know is watching tonight, but they accompanied us frequently. This picture is over 40 years old, but here are 2 of our girls getting their daily bath. And it has made a difference since they have continued to develop an interest in this part of my professional life. I retired in 2008 from the Maine Medical Center and started to work in East Africa, which has been probably the most rewarding portion of my career since I was able to develop an expanded period of time. If you look at Africa, it's bigger than you can imagine. It can fit China, Western Europe, the United States, India, Argentina, a few extra countries in its landmass. What this means is that with the limited physicians available who migrate to urban areas, we have a huge rural population with no or very minimal MD clinical care. My wife, Christine, and I left for Tanzania following my retirement. We worked there for 3 years, 8 months a year. I as a surgical educator, she as a social worker. At that time in 2000, a series of goals were created by the World Health Organization to set some standards for care in a global setting. These were some of the goals. They had to do with social improvement, education, correction of poverty, women empowerment, but the focus for us as healthcare workers in terms of surgery was not highly recognized at that time. As you can see, malaria and other diseases were emphasized, and also maternal and child health and mortality, which is the part that I was involved in. The thing to emphasize is that when you look at the global needs for healthcare, injury alone from trauma, nothing to do with cancer or any other needed surgery, far exceeds HIV, AIDS, TB. What am I doing?
To admit people in the waiting room.
Am I doing something wrong?
No, you're fine.
Okay.
Okay, sorry, keep going.
Doesn't want to advance now. Oops, you go back. So what we had evolved in East Africa and many of the countries is after they received their independence in the 1960s, and with these large geographic areas, there was no available medical care from traditionally trained physicians. So they evolved a process of non-clinical physicians to provide this care. In addition, some of the challenges were they were competing with traditional healers, which were part of the healthcare system. This is a picture of a young child, usually a month or two old, who has a common diagnosis, pyloric stenosis, which is an obstructed stomach, and was seen by the traditional healer and is scarified. These were created in hopes of correcting the abnormality, which obviously it didn't, because after these lacerations healed, they then came to us for further care. Transportation is a major issue. This is the rainy season, and you can't get to any of the clinics. Transportation for patients is difficult. I'm actually in that Land Cruiser going to one of our clinic visits. And I worked, and Dr. Pandya worked when he was there, in the referral hospital. This was the regional referral hospital for almost 3 million people. This is not a district facility, but this is would be the equivalent of referring your patient to the main medical center from rural Maine. We had an anesthesia machine, which you see on the right. It's a vaporizer. On the left, there's no oxygen supply. You have a, what do we call it? It's the,
Concentrator.
yeah, an oxygen concentrator. But their decision to provide medical care for the majority of the population was, instead of task sharing, they went to task shifting. So it was the equivalent of assistant medical officer with 5 years of training, could manage medical, pediatric, and limited surgical diseases. This was a project that I became involved with through the Bloomberg Foundation, the ex-mayor of New York City, and the Tanzanian Ministry of Health. And the idea was to bring surgical care closer to the population in need and provide additional training and infrastructure. So if we look at this, we say, well, this facility can't match anything we do in our Western counterpart. And what's the value? I mean, can we really provide care in terms of minimizing morbidity and mortality? Well, when you look at what they do, the majority of procedures, 50 to 60% of cesarean sections, and if you look at 2/3 or 75% of what they do, there are a number of limited procedures which they do frequently and they do well. And this is the greatest source of mortality and morbidity in these countries. It's not the fancy 10-hour prolonged operative procedures, which help a few in our healthcare system, but they can make a significant dent in minimizing mortality and morbidity. I show you this, there are two important messages here. This is Dr. Pandya doing his first C-section. He's being mentored by Dr. Leonidas, the senior assistant medical officer. And they do maybe 100 of these or more a year, so they do them very well. The second important point is you notice they're both wearing headlights. This is not an advertisement for LL Bean, but frequently we lose electricity during the day. That's okay because we have ambient light from the outside. But during the 3 years I was there, they never were able to fix the emergency generator. So if you're doing cesarean section in the evening, you might find it difficult to complete the operation in the dark. And there's several countries in East Africa, Kenya, Uganda, where they did not feel that non-physician clinicians were always the best choice for the population. But by limiting the number of physicians that could do surgery, the mortality and morbidity went up for certainly obstetric care. And when you looked at some of the meta-analysis that were done, the clinical outcomes did not differ significantly from clinical officers and MD doctors, and also anesthesia training decreased maternal mortality. Surgery without safe anesthesia would be unsuccessful and poorly programmed. Before we arrived in 2009, only 25 intubations and 46 spinal anesthetics were used. Endotracheal intubation is important because it protects the airway when you're receiving general anesthesia and avoids aspirating and creating a serious complication from surgery. Within that first year, with training, that number went from 25 to 233 and 191 for spinals. In the first 5 months of 2010, we already exceeded endotracheal intubation from the preceding year. And here we have a boarded Tanzanian anesthesiologist from Dar es Salaam training the nurses to do intubation and safe anesthesia. And the other criteria that the project had is that you couldn't necessarily get a woman in labor to a facility to have a cesarean section when the ability to travel was limited or impossible. So they created operative environments in rural clinics by giving them an operating room similar to what we had in the referral hospital, and also the ability to type and cross-match blood. And they were very successful. The morbidity and mortality during the first few years was amazing. I then moved, the project in Tanzania was finished after 3 years. And in 2012, I got involved through Operation Giving Back in the college work in Rwanda. The need for surgical training in many countries was something that had not previously been discussed and emphasized, but was brought to the attention of by Farmer and Kim, well known in the global medicine world, and adopted the descriptive of the neglected stepchild of global health. And subsequent to that, in 2015, at the end of the first Millennium Project, the Lancet Commission created a document emphasizing the need for surgical care in global health, and had several goals that they wanted to emphasize. 5 billion people, when the world's population was 7 billion, lacked access to affordable surgery and anesthesia. And they had a target, which may be generous, to improve that to 80% coverage by 2030. Additional surgical procedures were needed to save lives each year. There were 300 and some odd million procedures performed worldwide, but only 6% in the poorest countries, which had greater than a third of the population. Medical illness, surgical illness, and specifically was catastrophic for patients in terms of covering these costs. And the other important message about surgery is that it is cost effective. One of the arguments early on is that it's expensive. You need complicated equipment, but it showed simple procedures which avert disability can be on an expenditure scale beneficial. If you can fix someone's incarcerated hernia and they can go back to work, they then do not become a social deficit to their society. And these are the things that went untreated. This is a femur fracture that came to our clinic 6 months after its occurrence. This has significant disability if not corrected, or should have been managed early on. So the project I got involved with was a collaborative partnership between USAID and the Rwandan Ministry of Health. This was a 7-year program. Several medical centers and universities was involved with this partnership. $170 million was set aside as a block grant. Now, a block grant doesn't require an NGO to come in and tell you what to do. This was given to the ministry, and they would decide how to distribute the money in terms of the required personnel. And these were physicians, nurses, dentists, hospital managers. And they wanted to develop a Western model. So what they wanted us to do is to create a residency program and eventually a self-sustaining faculty to provide their own training after 7 years. If you look at the country as a whole, they were devastated by the genocide in 1994. Most of the doctors either left or didn't survive. So their residency development was quite limited at the time we got involved. And the other thing is, this was a Western model, and it was possible to do this as opposed to Tanzania, which is a much bigger country. Rwanda is about the size of Maryland. It has a good infrastructure in terms of roads, and it had a strong emphasis by the government to provide medical care, and there's a limited health insurance program for the population. When I arrived in January of 2013, there was no pediatric surgical care for 12 million people. Year one, there was a twinning program, and I was partnered with an individual who was quite talented and became interested in pediatric surgery. Year two, he left for a fellowship at Kajabi in Kenya. He returned on year 5 in 2017 to complete his training, pass his oral and written exams, and return to Rwanda as the first accredited pediatric surgeon. In year 8, the second fully trained accredited pediatric surgeon from Rwanda began his work in the hospital. There are challenges. The more rural parts of Rwanda are not necessarily always well connected in terms of finances and education to the main healthcare system. There's some limited understanding by both the population and the physicians. There's delays in transport, and facilities, even though they may get to our referral facility, there may not be time in the OR, there may not be ventilators available, where there may be easier access in some of the private hospitals in the capital. So there's certainly still an inequality of infrastructure distribution. This is Dr. Edmund, my twin, although we don't look alike. Here we are the first year when he became interested. Here I am helping him through a operative procedure. Here he is returning years later with Dr. Jules, the second pediatric surgeon, and now I'm the scrub nurse, which is appropriate in terms of the development of pediatric surgery care. We're also fortunate to train a pediatric anesthesiologist. And the NGO Kids OR gave us a pediatric operating facility, which is quite nice. Heo Kartik and I are operating together on one of his frequent visits. And it's not sufficient enough to just train these people. You need to have continuing support. We now have 2 Rwandan pediatric surgeons for 12 million people, half of which are less than 15 years old. Maine as a state has 1.3 million. We have 4 pediatric surgeons. And so we want to avoid burnout. So here we have one of our pediatric surgeons from the Maine Medical Center, Chris Turner. We have one of our residents, and we have the 3rd year residents in the training program that rotated through our service. And this is what I leave you with. We now have 2 young pediatric Rwandan surgeons who will develop a pediatric surgery service for years to come. The short guy in the middle is no longer necessary, but will be available to help. And I think this is what we need to do. We need to provide ongoing support, because just providing trainees with the experience is not enough. They need to be supported and need support in terms of providing educational facilities. I now turn this over to my esteemed colleague, Dr. Pandya.
Thank you, Dr. Curci. He got the pull on the heartstrings portion of the talk, and I'm going to give a little bit more on a 30,000 foot perspective. So oftentimes as surgeons, and even as people that are interested in global health outreach, we get involved in short-term medical missions. And I'll talk a little bit about the short-term medical missions and maybe what the best practices are. In my experience, which is still fairly young in global health work, I continue to learn. There's a a term which is a little bit off-putting. It's called reverse innovation, where somebody from a Western mindset or a high-income mindset will come to a developing country and then come back learning something. And in reality, it's a bi-directional, constant flow of information. I learn things every time when I go to another healthcare setting, whether it's another hospital in Maine or another country altogether. And the part of that things that you learn are not just medical, but also in the introspection required to have a good long-term relationship. Not every medical mission is a long-term relationship. The type of relationships that Dr. Curci has described through Tanzania and Rwanda are long-term medical relationships where there is the ability to see patients, to see your colleagues, and to develop programs and to be a resource over a long period of time. Sometimes you need to be involved in a short-term medical mission, or maybe that's all that you're able to do in your current situation. As a practicing pediatric surgeon, my time is mostly owed to my patients here in Maine. And out of that, out of the 52 weeks out of the year, I take about 2 weeks that I'm contractually allowed to go and work in a low and middle income country. And a few things need to be core principles. And this is what people have described as good measures. So core principles are you should have appropriate recruitment and participation of the volunteers, meaning if you're a volunteer or if you're in charge of volunteers for a medical mission, you need to identify people that share values that are cohesive, individuals that will put aside any primary gain that they get from this and really look towards the bigger picture, even if your time in that country is limited. The power dynamic is really important to understand. The concept that as a visiting high-income country physician or organization, when you arrive in a low-income country, it is really important to understand what the host partner needs. And one way of doing that is to a priori understand that the host partner should define the relationship and really provide the needs assessment. Just as I cannot, through the Zoom conversation, know what you will need in your refrigerator the next day until you tell me, I cannot really tell what a host country or host partner will need sitting here in a high income country. So that dialogue needs to be early and it needs to be very honest. And it can't just be that, well, I have a lot of this and therefore that's what I'm going to bring. Sustainability and continuity of the programs, even in the short-term medical missions. And a lot of what I describe and my involvement has been short-term in the actual time allotted in the country. However, my relationships end up being long-term relationships. I'll give you an example. Earlier last year in 2020, I was in Rwanda, and it was my 4th time in Rwanda. It was an enjoyable experience, it was a challenging experience. And after I left, really the pandemic became a true global pandemic, leading to restrictions as we're all living with now. And it was a very depressing time in that we were not able to plan our next trip to Rwanda. We were not able to, which is the next step in our relationship with the teaching program in Rwanda, in Kigali, Rwanda, is to have a resident from Rwanda come to the United States on an observership and see different ways teams work and resources are used. And so we started figuring out ways of staying engaged. And one of them was to remain current in literature. It's really difficult for a practicing surgeon to remain current in literature. Every month, dozens of journals come out. And one way I thought we could contribute was to create a digest. of our pediatric surgery journals. You go through them, 30, 40 articles, summarize them, and send them to your colleagues in countries that may not get a current issue, may not have the resources for it, to make sure that they remain engaged, that no matter where you are, the medical community remains a family, a small group of individuals caring for a great amount of disease burden. And you can remain connected despite having great geographic distances and healthcare restrictions like this pandemic. Sustainability really not only is that ongoing engagement, but also that the needs remain addressed by and defined by the host organization. I can imagine that in Rwanda, with 2 pediatric surgeons and maybe a third coming in the next 3 to 4 years, that the need for a pediatric surgeon from a high-income country going to Kigali is no longer going to be the paramount importance. But I can guarantee that there will be an ongoing need for academic collaboration and education sharing, and also the cultural exchange that occurs whenever there is even a short-term medical mission. And then respect for the local governance, legal and ethical standards. It takes a lot. A lot of these things are ingrained into our medical training and the concepts of non-malfeasance, benevolence, justice. And you have to understand the context in where you're practicing in a low and middle income country. It takes a long time to understand that. And one of my mentors from medical school, a surgeon, he described it this way, that he would tell his residents that don't just operate, stand there. And that was flipped on its head of what a surgeon is potentially designed to do, is to intervene with limited information. And here you really have to take a thoughtful approach before speaking or acting. And also the regular evaluation of the program, any of the short-term medical mission programs, to make sure that the host community is, again, comfortable with this arrangement. It takes a lot for the power dynamics to be to a point that the host organization or host country feels comfortable telling the visiting organization that, we don't need this, we need this, we need more education, or we need more service, etc. This is an article that I found really compelling. It was by an Indian surgeon, Novajit Roy, who gave a lecture, the Hugh Greenwood lecture at the British Association of Pediatric Surgeons in 2017. And the article is titled A View from the South. And one of the quotes in it, which was quite compelling, was that it is hard to teach a man to fish in his pond without getting to know his pond first. Some of the concepts in this article were really important, and we see this from time to time with programs that I've been involved with personally, and others that are described, where as a part of a humanitarian outreach, the things that are brought over to a low and middle income country, to a host country, it outmatches the technology that's brought. So examples were during major catastrophes in the world, such as earthquakes or floods or tsunamis, when humanitarian efforts have been conducted and people have done things as simple or as common as setting bones that are broken, they often will use high resource type of things. So they may use, for example, for a leg bone fracture, they may end up using plates and screws and fluoroscopy, etc., when in reality, there's no way to recover from a problem that may happen after that humanitarian effort and that surgeon leaves that country. Because historically in that country, it may have been that many of these fractures were fixed with more simple measures, such as casting or with external fixators that can then be cleaned and used again. It's also important that if you are only in the disaster zone for a short period of time, provide the healthcare and then leave, you will not know what the complications and the problems that occurred after you left. And you'll leave those problems for the physicians that are remaining. And without that follow-up, without long-term, that relationship or long-term effort, it puts a lot of strain on that hospital and that provider to care for those patients. One of the concepts that I try to also incorporate is the educational or the consultation-based arrangement, where we're more digital and connected than ever before. And if a physician in a low or middle income country needs help, they will reach out to you and ask consultation help with a patient. And that can be quite impactful. The other important thing is you need to understand what the actual burden of the disease is in that country. And surgical burden of disease, as Dr. Curci alluded to, the things that often will catch the headlines are the 10-hour operation to help separate conjoint twins, when in reality, the things that are most impactful may have been fixing hernias, dealing with infections that occur, surgical management of infections, and things of that nature that really can alleviate a lot of burden. They're what we call bread and butter things in medicine that really are impactful. And I'll dwell a little bit on this. One of the articles that looked at what we call the 7 sins of humanitarian medicine, which is when you don't have inadequate follow-up and you're leaving a mess for people to clean up behind you. The example here is of early experience in Operation Smile, where it's a very common problem that occurs when you have a cleft lip or a palate where the top of the mouth is not formed and the babies are not able to eat and drink properly, or there's significant cosmetic issues. And many of these cleft lip and palate operations were done in large numbers, but didn't have the proper patient selection, which can lead to problems where postoperative care is not performed. We talked a little bit about matching technology and to the local needs. Another big problem that when you work in LMICs is to look at the lack of coordination with other agencies and with each other. There are many NGOs that work in proximity, but not collaboratively. It takes a lot of coordination for any organization to reach out and work with a host country, with their government, with the hospitals, with individual providers, but know that just having some coordination between 2 NGOs or between a non-government organization and other infrastructure that may exist in the country, such as the military or something of that nature, can be quite impactful and leads to less waste in the whole process. Another important thing is allowing politics to override service. This is something that many things can be co-opted in medicine and in efforts to provide service, where you're not able to separate the actual the request from the host and what you're able to provide that may be co-opted by political issues, that it's not a there could be some political interference with that. So try to keep the motivations as pure as possible. Being unwanted guests, so understanding that relationship and knowing when it's a time to say that we've done what we came to do and what the host wanted us to do, and now we should move on. Doing the right thing for the wrong reason. Know your intentions, know your impact of the medical mission trip, and it's not a a mission trip to go to a different part of the world that you've not seen before for the sole purpose of visiting that place. It's to understand the need in a country in the world and to understand how you can contribute to it. We've learned a lot of things. I continue to learn in this journey, and adapting to different challenges is the name of the game. Don't underestimate serendipity. This is a small world when it comes to medicine. It's a smaller world when it comes to pediatric surgery. Dr. Curci was in the last portions of his program directorship when I had the opportunity to go with him to Tanzania. And then later on, despite him working mostly in East Africa and me training in the West, eventually I was able to work in Kijabi, Kenya with Dr. Edmond, who is the first pediatric surgeon in Rwanda. We trained around the same time. I trained in Montreal, he trained in Kijabi, Kenya. We had a bilateral relationship in that he came to Montreal for several months for training and for the cultural exchange, and I went to Kijabe. And that relationship has endured. That's the reason that I keep going back to Rwanda, and out of many other places that I potentially could be, is those types of relationships. It's definitely a small world. Engage even when afar. Dr. Curci is very good about this in patients that we have worked with. Surgeons in Rwanda, we will frequently send out emails to see what their follow-up is and if they run into problems and if we can help with those problems. Relationships can be, again, transactional, but also mutually beneficial. And what I mean by this is sometimes it's as simple as, I need you to be here in Kigali for this long so I can have respite because I've been on call for the last year solid, and I need to see my family. I need to visit my wife and my kids who are in another country. And so it's transactional, right? We say, yeah, we'll be there, we'll cover, and but it also is mutually beneficial because to have a physician burnout that far away with that low resource is quite devastating for that whole country. Bidirectional education is the bedrock. This is where you're able to engage both at high resource type of therapies, but also practical therapies that have to work even in low resource settings. Understand the power dynamic. This is something that I learned as a third-year resident working in Tanzania. It's very important to observe and see what the real challenges are. It takes a while to absorb everything. It's like opening your eyes in dark and waiting for them to adjust before you can truly see everything. Relationships take time. There's no rushing this process. There can be some precipitating circumstances where you have to have a very intense relationship, say a disaster, etc. But a relationship where you can engage with that person again takes time. Tread lightly. This is in many ways. We sometimes have a feeling that we are masters of knowledge or resources, and that's again not the case. You have to learn from everyone around you. There's a saying, and it's I don't think it's attributed to anybody that I can find. It's often attributed to the continent of Africa, which is laughable because there are so many different cultures. But it's something that I think is true, that if you want to go fast, go alone. If you want to go far, go together. That's the end of our talk. Thank you very much, and we're happy to take questions.
Okay. Turn the camera on. Yeah. Hi, everybody. So, thank you very much, Dr. Pandya and Dr. Curci. And I think we have a few questions in the chat. Let me go back up here. Tenzin, are you still on, Tenzin? It would be okay if you would like to unmute yourself and ask your question.
Hey, all. And I was wondering, with the majority of care being needing for different types of injuries, what kind of injury do you see most often that is requiring actual surgical intervention?
The most frequent by far and away is orthopedic issues. Extremity fractures are extremely common, and an orthopedicist's work is weight in gold.
And then just my second question was, with the headlamp situation, without your reliable electricity and whatever that oxygenator device was that looked like a shop vac, when you have intubated patients ventilated, are they just entirely hand bagged? Is there a different ventilator system?
No, you're quite correct. There's that in the background of the slide I showed. It's a hand pump. Nothing's automatic. You need strong arms and hands.
There's a little more I can add to that. This is, again, one of those outmatching the local technology with donations. And it sometimes can be not necessarily poorly thought out, but it's just poorly supported. So ventilators have been distributed to many district hospitals and regional hospitals and referral hospitals for sure. But the technicians required to troubleshoot them and the training for the anesthesia teams doesn't exist. And so they will often just sit in storage, and the things that are tired and true, which are hand bagging with a mask, using an ether vaporizer and an oxygen concentrator, are what ends up being used, since it's worked in the past.
Yeah, I have one.
Well, thank you both.
Well, what's excluded from the picture that I showed you, for many months, there was an anesthesia machine which had been donated sitting in the corner, but since we had no oxygen supply, there was no way to run this machine. So we finally put it in the back room.
I think that this is a common challenge in many parts of the world, not just where the two of you were, because we've seen it quite often in many of our medical missions that we've had here at Partners for World Health in different places like Bangladesh and other places in Africa. So anesthesia and lack of, as you indicated, they have the machine, but they don't know how to use it. And so many times things are broken and when they don't have biomedical support to fix it. A big challenge. So one of the big things to bring always is an ambu bag.
There is some technology that is available. Certainly ultrasound is equivalent to the CAT scanner in our culture. They're gotten to be smaller. So if they need repair, they can be carried in your backpack back home, where the earlier machines went into the junkyard because there was no biotechnician. There's a new piece of technology where you can adapt your smartphone to do ultrasound at the bedside. And there is some technology that will be available, not necessarily high cost, and can be repaired, not easily, but certainly doesn't have to be discarded.
One of the other things in particular in surgery is, as a new trainee in any country, you want to be technically and technologically relevant. So if you know that your colleagues in other, say, middle income countries are training in laparoscopy, and as a part of your work, which would be government, but then also some private practice, that you need to do and learn laparoscopy, that is an enormous expense that some countries have been able to train some of their trainees in. But not every trainee would be able to, say, use the one laparoscope in the operating room. And so one of our educational efforts was to create a low-cost, high-fidelity laparoscopic trainer made with basically corrugated cardboard and plastic to simulate laparoscopic skills and to teach laparoscopic skills. And that was really, really well received. And so it's this balance that you seek where you don't want to hamper someone's ability or imagination for a better way of doing something just by saying, well, you only have an ether vaporizer here, so these are the only cases that you'll be able to do. At the same time, you don't want to unduly stress the resources to do something just so it can be the first laparoscopic, gastrostomy tube placement in. It's not. You have to make sure that it's a realistic and practical thing for the country.
Thank you. So let's see here. So we have another question by Brianna Philbrook. Are you still here, Brianna?
I am still here.
Great.
So my question was about medical student involvement in global health. Just generally, how appropriate do you think it is? Obviously, that relationship is slightly skewed toward benefiting the medical student with little they can give back. And I would say the same is probably even true for people in earlier years of residency. Just what are your thoughts on early involvement and how early is too early?
Well, I started early. I was in a somewhat progressive program where 10% of the class had the option of doing a rotation either in Africa or in South America. And I think there is a need, and I think if you're going to get involved, it's never too early to start. And there are things that medical students can do. I've taken medical students to Haiti with me, and it either satisfies your interest and not to be pursued again, but also for some, there has been long-term interest and investment. So I think there is a place for it and should be encouraged.
That's a great question, Brianna. And this is the part of the introspection that everyone does, hopefully, when they engage in these types of efforts. But understand that if you are not involved in global or outreach programs as a medical student or as a surgery trainee or through your medical training or as in your fellowship, then the chance that you will go out and do something like that when you're in practice is about an order of magnitude less. So this is something seen and described in plastic surgery literature where residents that were involved in a plastic surgery global outreach as residents were about 60% likely in their private or in their practice to actually be involved in global outreach, whereas those that were not were less than 10%. So if you never experience it, no matter how limited your role may be or what you think your contribution may be, you're likely not going to incorporate it into your work for the rest of your life. So I think that again we can definitely be attuned to the issues that can develop. As a medical student, you are very interested in wanting to get clinical exposure, but it doesn't necessarily have to be at the expense of trainees in that host country. It shouldn't be at the expenses of those trainees. It can be done together. And we see that a lot in Rwanda, where many European medical students will join and be kind of integral to the program.
I think that's a very good point, that the sooner you have the opportunity to do that, in the long run, you will participate. And there are so many benefits for participating in a medical mission, not just providing the surgery or the clinical aspect, it's that relationship that you develop with the patients and also with the staff with whom you're working. So really important to think about doing that early in your career. Is Peter Mazzaglia here?
Mazzaglia.
Mazzaglia. Why do I know that name? Peter, are you still here? So Peter asked a question, is funding from your ongoing work coming from the government or NGO services sources? Will the programs like USAID exist in the future, or will this type of work be mostly privately funded?
I can't answer that question. My work over there is, and it's a very limited stipend, but it's funded by basically USAID, but it's my salary comes through the Ministry of Health in Rwanda. Because of their block grant, they control the expenditure for physicians' payment, their decision how many of a given type of physician they would like. And what happened, they had a 7-year program to start with that was extended by 5 years in 2019. As you might expect, there wasn't a great enthusiasm given our past president to invest in Africa or other developing countries. But the World Global Fund and some other funds, not just from the US, but European, have provided the funding for the project to continue. One other comment that I would make about developing your interest in global medicine is to find a mentor. Find someone in your medical school. In my case, it was the head of the parasitology department who trained the physicians for the Peace Corps. But if you can find someone that can provide contacts and even develop projects that they might be interested in terms of research, I think that's one place to start and may be very effective.
Thank you, Dr. Curci.
Just a quick comment about funding. Majority of funding for pediatric surgical care, it actually comes from NGOs, from non-governmental organizations in sub-Saharan Africa. So it's not the host organizations that end up funding a lot of it. And a lot of, Dr. Curci is supported through the program, but Drs. Turner and myself, we're not. We do this all out of our own expense, and it's a definite investment. We find that we get more out of it than we put in. But that's another challenge, is not so much the funding, but the time, and to convince your partners, or more commonly now, your multi-specialty group or your hospital, that this is a worthwhile investment in the time. And when you compare that with the exposure for medical students and residents and enriching their time in training, that usually is what allows you to have that support.
Thank you. Let's see. David Rothstein, are you still with us?
Yeah.
Hi, David.
Hi, David.
Hey, hi guys. Hey, everybody.
Would you like to comment, or would you like me to read this?
Well, no, I just wanted to, I think there are several people on this call that either trained at Maine Medical or worked with Mike and Christine abroad, who have shared in the Curci's family. And I just, as a graduate and an acolyte, I wanted to express my appreciation, particularly to Mike, for what he has taught us and the example he has set for us. The medical student who asked the question, I mean, I went as a resident, as did Kartik, I think, as many medical surgical residents from Maine Medical Center, that started a thought process that continued on into our lives. So it's greatly appreciated, and the mentorship is key, as everybody's pointed out.
Thank you.
Thank you, David. Yeah, and you've done a lot of work in the Congo until recently, trying to provide a healthcare system where none existed. So I think we're proud to see what you're doing, and it's exactly what these countries need and require.
Maybe he'd like to come and make a presentation for us in the future.
He's out in Seattle. It'll be difficult.
Oh, well, with Zoom, nothing
This
is.
is Zoom. If that could be next door, you never know.
Yes, well, we will be in touch with you, David.
Thanks.
Say hello to Sarah.
I will. Thank you.
And Ellen Milan, are you still with us?
Yeah, hi, Elizabeth. I'm still
Ellen.
here. Hi, doctors. As being a NICU nurse who's done 14 volunteer assignments in Uganda, I'm aware of, the capabilities of nursing care and everything. And these programs to teach surgeons, it's wonderful that there's more access to pediatric surgery. Is there any involvement in nursing staff as far as caring for these patients that have been operated on? How is the post-operative nursing care, and has there been any specialized training in these hospitals that you've worked with?
And Carol.
Yes, actually, Ellen and Ann Carroll are colleagues
Oh, okay.
and work together in Uganda, where we provide the medical mission through Partners for World Health at Malago Hospital in the NICU of 80 beds, 80 patients, very crowded, etc.
Yeah, I think one of the weaker links now, certainly in Rwanda, and I've spoken to Anne about this, is that they now have access to reasonably good surgery, nice facility, but they don't have the nursing care that's highly specialized that could care for some of these children. So I think that's one of the missing links which we need to focus on in the near future to support a more advanced surgical service in pediatrics.
Exactly, because as you know, as doctors, how important nursing is to the outcomes of any patient.
Yeah, there's no question about that.
Yeah, that's a great point. It's a concentric growth in the entire healthcare system, everything from medicine to surgery to pharmacy to logistics, transportation, nursing. It's just this concentric thing. And anytime one part of it grows, you see the limitations that you're bound by. I had the privilege of working in the training center, Bethany Kids, which is a missionary-based hospital in Kajabi, Kenya, where Dr. Edmond trained for pediatric surgery fellowship. And the difference, despite the hospital in Kigali being a teaching hospital, a government-funded hospital, comparing that to the mission hospital in Kajabi was stark. And it wasn't just the equipment, it was the ability to get the human resources for education, the nursing school that was there that had just a cadre of young nurses that were eager to take care of these patients. That made such a big difference in the quality. And, Dr. Curci and I, at least working in Rwanda, we're a little bit spoiled in that we do have the specialists that help manage patients. We do have, in some limited fashion, pediatric intensivists, pediatricians that are interested in neonatology, some nurses that are interested in neonatology. But when you look outside of the capital, it becomes even more stark, the lack of nursing care and resources.
Thank you, Ellen, for that question. Do we have any more questions?
One question from Eunice Wilcox.
Eunice,
Above Peters.
it's above where?
Above Peters. Name is Andrea.
I see only Ellen. I'm not, oh, Emma.
My question was, I just wondered if there were other surgical specialties that were using the twinning model, for instance, urology or neurosurgery.
Well, they made an attempt, and sometimes the twins were poorly matched. With all humility, ours was the most successful. I was fortunate to meet Dr. Edmond. He was bright and definitely has strong leadership skills, and it worked out well. But sometimes you paired an orthopedist with a thoracic surgeon, and so you have to be very selective. But ideally, that's what they would like to do.
Thank you.
The other twinning process that's worked reasonably well has been emergency general surgery and the acute care surgery, where they have a pretty strong collaborative relationship. And on the medicine side as well, there's pediatrics has been has a good track record in Rwanda.
I have one final comment for Elizabeth to show you the success and the help that she offers every year. Every year I take over several hundred, maybe more than several hundred endotracheal tubes. Very, very simple. Yet we cannot do safe surgery without these appropriate tubes, which I get charged by weight. So if I take 500 endotracheal tubes at a cost of about $25, I've made a major impact on what they can do over there. And unfairly, I'm treated as a god because I bring over these simple things that can now allow them to do safe surgery and do more surgery. And the credit has to go to the institution here, which provides this for me, since I'm not sure I'd be as welcome without Elizabeth providing some of the supplies I bring.
Well, thank you very much, Dr. Curci, but we are here to help. We have a huge collection that we have managed to amass from all over New England. And if people do know of anyone out there in our country that is interested in our medical supplies, either by carrying on a medical mission or through a container load, please let us know. Please let us know. So if there are not any more questions, I actually, before I introduce one more person, I would like to give you a present to say thank you. And this is a little present from Cambodia to you.
Thank you very much.
You're very welcome. And this is a little present to say thank you to you, Dr. Curci, from Peru. Fragile.
Thank
Please
you.
be careful when you open it. So thank you very much for coming. So I'd also like to introduce Dr. Arul Mahadevan, who will be speaking next month with his colleague. And Arul, would you like to say a few words about next month, rather?
Sure. Thank you, Elizabeth. And thank you to Michael Curci and Karthik Pandya. You both gave a wonderful presentation this evening. Much appreciate all the work that you are doing in Africa. And I want to thank all the participants, and I'm glad you could all join to these talks on Global Health Forum organized by the Partners for World Health. I have known Elizabeth for almost 5 years now. Partners for World Health is a nonprofit organization based in New England in the US, but very much conscious of the healthcare issues worldwide. COVID pandemic has brought into focus the fact that the population health has no geographic barriers. We are all in this together. If this past year has shown us anything, it is the remarkable resilience of humankind. We came together as a community and organized our way through these unprecedented times. However, many parts of the world have suffered greatly without the same resources that we are lucky to have. Many people across the world have faced these same challenges, yet are unable to obtain the same support. So next month, you'll be hearing from Dr. Ravi Kannan, who is from Silchar in a remote area, Northeast India, who has pioneered and organized cancer services for those who are unable to obtain them locally. I believe he's in this meeting as well. And I think you will have a chance to hear from him how cancer services, which is an essential need for people in remote areas who are unable to obtain them easily, in a way that they can feel good about themselves. So that's what you will see. Elizabeth and I had a chance to go visit that facility a few years ago. And I would encourage all of you and those around you to sign up and listen to that. Thank you.
Thank you very much, Arul. So are there any other questions? So we would like to thank all of you for coming. However, we do have our door prizes. And the first one is this book, The Translator, a tribesman memoir from Darfur. So Dr. Curci, would you just pull a name out of the hat, please? And this one is going to go to Dan Sobel. Is Dr. Sobel still on the call? He is, okay. So you can either come in to pick it up here at Partners for World Health. Love to have you come for a little visit. And otherwise, we'll make arrangements.
Thank you.
Hi, Dan.
Hi, Mike. I enjoyed the talk very much.
Great. So there's another little door prize here, your turn. This one is going to Lois Lefevre. She's a registered nurse here and one of our great volunteers. And we'll have this for you, Lois, here in the office when you come in next. So terrific. This is Lois. Two more. This is a book. This is a like a travel log notebook. Laura Sandstrom. Is Laura still on the call?
Yeah.
She is, okay. Okay, Laura, it'll be available for you here at Partners for World Health. And the last one is these little ceramic items were made by one of our volunteers here, Bonnie Beach. And Bonnie Beach has been a big supporter of us for the last couple of years and packs all of our suture boxes. She knows everything about sutures that she only learned from Partners for World Health. And this is going to Laura Withers. Laura is not here. Whoops. So we will pick again. And this one is going to Megan Palmer.
Yeah.
And Megan Palmer.
That's my daughter.
Is that your daughter?
That's nepotism. That's nepotism.
No, Kartik did it. I didn't.
No,
Thank you.
you're very welcome. We'll have it available here. We'll figure out, are they here? Are you here in Maine?
I saw them.
I am. I'm in Freeport.
Okay, great. Well, we'll make sure that we get it to you.
Thank you.
So thank you very much to everyone who's joined us this evening. Really appreciate it. And we will be having more information will come out through the email blast and on Facebook. So stay tuned for the programs that we have to offer, and also our medical mission program, which will start up again in the summer. The first trip will be in August to Ethiopia, followed by Bangladesh in October, and then to South Sudan, which is strictly a primary care mission in South Sudan in November. So we look forward to hearing from all of you, and we welcome you. If you're interested in becoming a volunteer, please give us a call. Thank you very much. Bye.
Bye.
Now, where do I just end?
Hit the video button on the bottom left.
Type the what?
Bottom left. Stop
Bottom
video.
left, stop the video. Okay.
Now I just make sure that the recording is. Stop recording.